Welcome to another episode from the Veterinary Medicine Digest. Today, we're diving deep into a topic that touches the hearts of many dog owners and veterinary professionals alike: lymphoma in our beloved canine companions. It's a complex and challenging disease, but our understanding of it is constantly evolving, bringing new hope and improved strategies for diagnosis and treatment. So, grab a warm drink, settle in, and let's explore the intricate world of canine lymphoma together. Lymphoma isn't just one disease. It's a diverse group of cancers that originate from lymphocytes, a type of white blood cell crucial for the immune system. In dogs, it's tragically one of the most common neoplastic diseases, representing the most frequently managed cancer in veterinary oncology. Estimates suggest a minimal annual incidence rate ranging from 13 to 114 cases per 100,000 dogs, and over the past few decades, this incidence has actually seen an increase. This upward trend mirrors what's observed in humans with non-Hodgkin lymphoma, leading researchers to believe that our furry friends and us might share common environmental risk factors. Indeed, the striking similarities between canine lymphoma and human non-Hodgkin lymphoma extend to clinical presentation, molecular biology, treatment approaches, and even treatment responses, making dogs an invaluable spontaneous large animal model for studying human non-Hodgkin lymphoma. While any dog breed can be affected, middle-sized to larger breeds tend to be overrepresented, including Basset Hounds, Bernese Mountain Dogs, Boxers, Bulldogs, Golden Retrievers, Labrador Retrievers, Rottweilers, and Scottish Terriers. Some breeds, like the Irish Wolfhound and Shih Tzu, are more prone to T-cell lymphomas, while Doberman Pinschers and Scottish Terriers more often develop B-cell lymphomas, strongly suggesting a genetic predisposition. Although lymphoma can strike at any age, it predominantly affects middle-aged to older dogs, with the incidence rate climbing significantly for dogs over 10 years old. Interestingly, there's no apparent sex predisposition generally, but intact female dogs might have a slightly reduced risk, and early spaying or neutering in some breeds like Golden Retrievers and Vizslas has been linked to an increased risk. Now, what causes this perplexing disease? The exact cause of canine lymphoma remains elusive, but several factors are thought to play a significant role. Environmental elements are under close scrutiny. For instance, living in industrial areas, exposure to household chemicals, proximity to waste incinerators, radioactive or polluted sites, and even exposure to magnetic fields have all been associated with an increased risk. While some early studies linked exposure to the herbicide 2,4-dichlorophenoxyacetic acid to canine lymphoma, later reanalysis couldn't confirm this definitively. However, the observation that defective genotypes of certain detoxifying enzymes, like glutathione transferase, are overrepresented in human cancers and also found in canine lymphoma cases supports the idea that environmental toxins contribute to carcinogenesis. DNA damage repair capacity also seems to be a factor, as Golden Retrievers with lymphoma have shown a lower capacity for DNA repair compared to healthy dogs. The question of a viral etiology is also fascinating. Many animal species have their own leukemia viruses, making the existence of a canine lymphoma virus a plausible theory. While some studies have detected reverse transcriptase activity or a gamma herpes virus in canine lymphoma cases, a definitive viral cause is not yet widely accepted. Additionally, a dysfunctional immune system is another area of interest. In humans, conditions like HIV infection, immunosuppressive therapy, autoimmune diseases, or immunodeficiency disorders increase lymphoma risk. In dogs, autoimmune diseases are frequently reported alongside lymphoma, and there's a documented case of a dog developing lymphoma after cyclosporin treatment. An increased risk for cutaneous lymphoma has also been noted in dogs diagnosed with atopic dermatitis, possibly due to immune dysregulation. On a deeper level, the molecular biology of canine lymphoma reveals remarkable parallels with human non-Hodgkin lymphoma. While research is ongoing, specific genetic abnormalities are being identified that hold diagnostic and prognostic value. Comparative genomic hybridization has shown some genomic instability in canine lymphoma, particularly in dog chromosomes 13 and 31, which correspond to human chromosomes 8 and 21. The proto-oncogene c-KIT, involved in cell proliferation and survival, is typically low in canine lymphoma but can be increased in some high-grade T-cell lymphomas. Mutations in tumor suppressor genes like p53 are relatively rare, but appear more common in older animals, high-grade, and T-cell lymphomas. Overexpression of specific genes like IKZF2, CCL4, and SAA1, and downregulation of CD40, particularly in T-cell lymphoma, have been associated with shorter survival times in humans and may similarly impact canine T-cell lymphoma outcomes. Conversely, upregulation of HERC5 may contribute to canine lymphoma pathogenicity, while low expression of IL-7 are in lymphoma dogs, also linked to increased tumor growth and lower survival rates in humans, suggests a poor prognosis. Now, let's turn our attention to how lymphoma typically presents in dogs, which can be quite varied. The most common presentation, accounting for about 75% of all cases, is the multicentric form, characterized by generalized, non-painful enlargement of peripheral lymph nodes. This is classified into 5 stages by the World Health Organization. Stage I, single lymph node. Stage 2, regional involvement of multiple lymph nodes. Stage 3, generalized lymph node involvement. Stage 4, involvement of liver and/or spleen. And Stage V, involvement of blood or bone marrow. We also add a substage, for absence of systemic signs, and B, for presence of signs like fever, weight loss, or hypercalcemia. Beyond the multicentric form, lymphoma can manifest in many other ways, affecting various organs and body systems. These are often referred to as extranodal forms. Mediastinal lymphoma is more common in younger dogs and is almost exclusively of T-cell origin. Clinical signs might include difficulty breathing due to a mass effect or fluid in the chest, increased thirst and urination from high calcium levels, or a condition called cranial vena cava syndrome, where a large mediastinal mass restricts blood flow, causing swelling in the head and neck. Gastrointestinal lymphoma can affect dogs of any age, sex, or breed, though boxers and Shar-Peis are frequently reported. It's typically T-cell in origin and can appear as a single lesion, multiple lesions, or diffuse disease. Signs can be vague, and while ultrasound can help, a definitive diagnosis usually requires a biopsy. Eosinophilia, an increase in a certain type of white blood cell, is a common associated condition in canine gastrointestinal T-cell lymphoma. Hepatic lymphoma, or primary liver lymphoma, is relatively rare and carries a poor prognosis compared to other forms. Survival times are often short, and certain clinical signs like leukocytosis, neutropenia, low albumin, or high bilirubin reduce the likelihood of a complete response. Cutaneous lymphoma is usually a T-cell lymphoma, often affecting the skin and sometimes mucous membranes. The most recognized form is mycosis fungoides, a CD8-positive T-cell lymphoma mainly seen in older dogs, though boxers and Bichon frises appear to be predisposed. Lesions can vary widely, from redness and scaling to plaques and nodules. Ocular lymphoma is quite rare as a primary condition. More commonly, lymphoma can cause secondary uveitis. It's mostly of B-cell origin and can present as an intraocular mass or conjunctival disease. Nervous system lymphoma is also uncommon but can affect the central nervous system, including the brain and spinal cord, or the peripheral nervous system. It often presents as a multifocal disease, leading to signs like seizures, changes in mental status, ataxia, or paralysis. Pulmonary lymphoma, affecting the lungs, is common in canine lymphoma but rarely causes respiratory signs unless it leads to fluid in the chest. It often appears as infiltrates in the lungs or enlarged lymph nodes in the chest on diagnostic imaging. Beyond these, lymphoma can technically affect almost any organ, leading to various atypical forms reported in areas like the mouth, nose, bones, kidneys, bladder, uterus, prostate, heart, and even adrenal glands. Adding to this complexity are paraneoplastic syndromes, which are conditions that occur as a result of the cancer's presence but aren't directly caused by the tumor invading tissue. The most well-known of these in canine lymphoma is hypercalcemia, or abnormally high calcium levels in the blood, which is found in 10 to 15% of cases and almost exclusively associated with T-cell lymphoma. This occurs because the cancerous cells produce a parathyroid hormone-related protein. High calcium levels can lead to increased thirst and urination and even acute kidney failure. Other paraneoplastic syndromes include monoclonal gammopathy, hypoglycemia, polycythemia, in renal lymphoma, eosinophilia, and immune-mediated diseases like immune-mediated hemolytic anemia and thrombocytopenia. Diagnosing canine lymphoma involves a comprehensive approach, combining clinical signs with various laboratory and imaging techniques. Clinical pathology routine blood work can reveal a range of nonspecific abnormalities. Many dogs might have a mild to moderate non-regenerative anemia, though anemia can also result from blood loss, such as in gastrointestinal lymphoma, or from immune-mediated hemolytic anemia. Rarely, increased red blood cell counts might be seen in renal lymphoma due to inappropriate erythropoietin secretion. While leukocyte counts are usually normal, both increases, leukocytosis, often an inflammatory response, and decreases, leukopenia, can occur. Thrombocytopenia or low platelet count is common but usually mild, though thrombocytosis can also be observed. Mild abnormalities in blood clotting are also frequent, consistent with a state of hypercoagulability. Liver or kidney enzyme elevations might suggest organ involvement, but more often reflect secondary issues like reactive hepatopathy or dehydration. Lactate dehydrogenase activity, a prognostic indicator in human non-Hodgkin lymphoma, has shown inconsistent prognostic value in dogs and isn't routinely recommended. However, hypercalcemia, present in about 10 to 15% of cases, is a significant finding and almost exclusively associated with T-cell lymphoma. Urinalysis isn't routinely performed but can show proteinuria, which typically doesn't affect prognosis. Bone marrow involvement, indicating stage V disease, is reported in up to 55% of dogs, but it can't be accurately predicted from peripheral blood counts alone. While a bone marrow biopsy is an invasive procedure, cytological examination of an aspirate remains the most common technique for assessing involvement, though it has limited impact on treatment decisions, unless the involvement is massive. Diagnostic imaging plays a crucial role in staging and assessing the extent of the disease. Thoracic and abdominal radiographs can show abnormalities in about 70% of cases, though these are often nonspecific. Thoracic radiographs might reveal enlarged lymph nodes in the chest, lung infiltrates, or a cranial mediastinal mass. Abdominal ultrasonography is valuable for assessing the size and architecture of lymph nodes and for detecting liver and spleen involvement. However, it's not ideal for diagnosing or ruling out gastrointestinal lymphoma, as findings can be nonspecific or even absent in up to 25% of affected dogs. Computerized tomography, or CT scans, provide excellent detail for evaluating the extent of the disease, but usually can't provide a specific diagnosis on their own. For example, a CT scan can show a cranial mediastinal mass but won't differentiate between lymphoma and a thymoma. Advanced imaging like PET-CT, combining positron emission tomography with CT, is a standard for staging many human cancers, but is less accessible in veterinary medicine. Scintigraphy using radio-labeled peptides targeting specific lymphoma markers has also been explored. Cytology, histology, and immunophenotyping for high-grade lymphoma, cytological examination of a fine needle aspirate from an affected lymph node is often the diagnostic method of choice due to its speed, sensitivity, and minimal invasiveness. However, for low-grade lymphoma or atypical lymphoid proliferations, cytology may not be enough. In these situations, a histological biopsy, preferably an excisional biopsy of a whole lymph node, is needed to confirm the diagnosis and allow for further subclassification. Canine lymphoma is classified based on morphological criteria such as growth pattern, nuclear size, mitotic index, and immunophenotype, using systems like the Kiel classification or the more recent World Health Organization classification. The WHO system, when applied to dogs, identifies diffuse large B-cell lymphoma as the most common subtype, 54%, followed by peripheral T-cell lymphoma not otherwise specified, 16%, nodal T-zone lymphoma, 14%, marginal zone B-cell lymphoma, 4%, and T-lymphoblastic lymphoma, 5%. Immunophenotyping, which identifies the specific type of immune cell-involved B-cell or T-cell, is critical for prognosis. About 70% of canine lymphoma cases are B-cell in origin, with 30% being T-cell lymphomas and a small percentage being non-B/non-T. This can be done on tissue samples using immunohistochemistry or on fine needle aspirates using immunocytochemistry or flow cytometry, all showing excellent correlation. Common markers include CD20, CD21, CD79A, and PX5 for B cells, and CD3, CD4, and CD8 for T cells. Flow cytometry, a sophisticated and highly quantitative technique, analyzes individual cells for physical attributes and expression of specific molecules, like antigens, using fluorescently labeled antibodies. It's especially useful for hematopoietic neoplasms, including lymphoma and leukemia, and can provide prognostic information. However, flow cytometry has stringent sample requirements, needs live cells, and isn't always diagnostic on its own, working best with other tests. It should be collected before steroid or chemotherapy treatment to ensure live, representative cells. PCR-based techniques. Another diagnostic tool is the polymerase chain reaction for antigen receptor rearrangement, or PARSE. This technique amplifies variable regions of immunoglobulin genes and T-cell receptors, and the presence of a monoclonal or oligoclonal peak strongly suggests lymphoma. PAR has high sensitivity and specificity, but some infections or other cancers can lead to false positives. While PAR can be used for immunophenotyping, it's less accurate than antibody-based methods and is usually reserved when fresh samples for flow cytometry or immunohistochemistry aren't available. Biomarkers: the search for specific biomarkers in serum that can diagnose or monitor lymphoma is ongoing. Thymidine kinase 1, a salvage enzyme involved in DNA synthesis, appears to be the most promising biomarker currently available, with higher levels in lymphoma dogs correlating with stage and prognosis. Other markers like haptoglobin, C-reactive protein, monocyte chemotactic protein 1, vascular endothelial growth factor, and matrix metalloproteinase 9 have been evaluated, but their clinical utility as standalone diagnostic or prognostic tools is still under investigation. Staging canine multicentric lymphoma is performed according to the World Health Organization scheme. This involves a thorough patient history, physical examination, and evaluation of peripheral blood and bone marrow. It is advised to include tests for hypercalcemia and immunophenotype due to their strong negative effect on prognosis. While thoracic radiographs and abdominal ultrasonography can provide more accurate staging, they only affect prognosis if a cranial mediastinal mass is found, so they may not be routinely performed for all cases. Bone marrow biopsies, while revealing important information, have little effect on treatment and are not routinely recommended unless there's massive involvement. Now, let's discuss treatment strategies for canine lymphoma, which primarily revolve around chemotherapy due to its systemic nature. The goal is always to achieve the maximum effect with minimal stress, side effects, and cost. Glucocorticoids, such as prednisone, are frequently used and can induce partial to complete remission, typically lasting 60 to 90 days. However, if chemotherapy is planned, it's generally recommended to withhold glucocorticoids beforehand, as pretreatment can lead to lower response rates and shorter remission periods to subsequent chemotherapy. Glucocorticoids are better reserved as palliative treatment or for later use in rescue protocols. For first-line chemotherapy, a variety of protocols exist. Single-agent therapy like doxorubicin can be reasonably effective, with about 65% to 85% of dogs responding, but response durations are shorter, typically 100 to 170 days. This is often considered for palliative care. Multi-agent protocols, particularly the cyclophosphamide, hydroxydonorubicin, doxorubicin, oncovin, vincristine, prednisone, or CHOP-based protocols, are considered the standard of care and generally yield the best results. These protocols involve sequential injections of vincristine, cyclophosphamide, and doxorubicin, often combined with daily prednisone for the first 4 weeks. Complete response rates can be as high as 85% to 95%, with median progression-free survival times of 5 to 9 months and median survival times of around 12 months. Unfortunately, nearly all patients, except about 5%, will eventually relapse. Most current CHOP protocols suspend therapy after 4 to 6 months, as recent studies show no added benefit from maintenance therapy beyond this initial period. Regarding specific drug modifications, O-asparaginase was once routinely included, but studies now suggest it doesn't improve outcomes and can be saved for potential rescue therapy. Oral versus intravenous cyclophosphamide. While injectable cyclophosphamide is traditionally used, oral forms, given at the same dose, appear to have similar efficacy because exposure to the active metabolite is comparable. Oral administration is convenient for owners, though injectable forms offer more precise dosing, especially for smaller dogs and cats. Prednisone omission. In cases where corticosteroids are contraindicated, such as in dogs with uncontrolled Cushing's disease or diabetes, studies have found that omitting prednisone from CHOP-based protocols does not negatively impact outcomes. All-oral chemotherapy protocols are appealing to some owners who are uncomfortable with injectable treatments. For specific types like cutaneous T-cell lymphoma, oral lomustine and prednisone can be effective, with about 75% to 85% of dogs responding. Dogs with low-grade or indolent lymphomas, such as T-zone lymphoma, may also respond well to conservative oral protocols like prednisone and chlorambucil. However, for most intermediate or high-grade multicentric lymphomas in dogs, an effective all-oral first-line protocol has not yet been identified. Relapse/refractory disease is an unfortunate reality for most lymphoma patients. If remission is lost after a period off chemotherapy, resuming the original CHOP protocol might induce a second remission, though it's typically about half as long as the first. For tumors that have become resistant, rescue or salvage chemotherapy drugs and protocols are considered. There are many options, including mitoxantrone, actinomycin D, lomustine, dacarbazine, rabacfocidine, vinblastine, melphalan, and temozolomide, as well as multi-agent protocols like MOPP, meclorethamine, vincristine, procarbazine, prednisone or DMAC, dexamethasone, melphalan, actinomycin D, cytarabine. Multi-agent rescue protocols generally have higher response rates than single drugs, but the average duration of response for both is usually in the 2 to 3 month range. It's important for owners to understand the law of diminishing returns, meaning that the likelihood of a robust response decreases with each subsequent rescue attempt. Information on rescue options for cats is more limited, but oral cyclophosphamide can be useful for low-grade small-cell lymphoma failing chlorambucil. Certain specific considerations influence treatment choices. T-cell lymphoma generally has inferior outcomes with CHOP-based chemotherapy compared to B-cell lymphoma. Alkylator-rich protocols like MOPP or LOPP, lomustine, vincristine, procarbazine, prednisone, have shown high response rates for T-cell lymphoma, though definitive evidence of a survival advantage over CHOP is still debated. Low-grade lymphomas, being slower growing, might be managed differently. In humans, a watchful waiting strategy is often adopted for indolent lymphomas. Similarly, for asymptomatic dogs with indolent nodal lymphomas, monitoring or low-intensity protocols like chlorambucil and prednisone are recommended, while splenic variants might only require splenectomy. Dogs with severe bone marrow, kidney, or liver involvement, or those at risk of tumor lysis syndrome, present unique challenges. These patients are at high risk of drug toxicity, so initial treatment might involve forced diuresis and drugs that cause less cell death or whose metabolism is organ-independent, like L-asparaginase or vincristine. Central nervous system lymphoma requires drugs that can penetrate the blood-brain barrier, such as L-asparaginase, cytosine arabinoside, and nitrosourea compounds. Intrathecal administration, directly into the spinal fluid, is another option for cytosine arabinoside. Drug resistance is a major limiting factor in chemotherapy. It's often linked to drug transporters like P-glycoprotein and breast cancer resistance protein. While P-glycoprotein expression was once considered prognostic, recent studies have not consistently confirmed this. Therapeutic approaches to overcome resistance include using inhibitors for these transporters or employing cytotoxic drugs that are not their substrates, such as alkylating agents and L-asparaginase. Beyond chemotherapy, other modalities are explored. Radiotherapy, though lymphoid cells are radiosensitive, has a limited role due to the systemic nature of lymphoma. It can be used for localized forms, as an adjuvant to surgery/chemotherapy, or as a rescue therapy for drug-resistant cases. Whole body or half-body irradiation can be used, sometimes combined with chemotherapy and autologous bone marrow or peripheral blood stem cell transplantation to mitigate severe bone marrow depression. While early bone marrow transplant reports showed high treatment-related morbidity and mortality, more recent data suggest improved tolerability. Immunotherapy is a promising area. Monoclonal antibodies targeting the CD20 antigen, successful in human B-cell lymphomas, are being developed for dogs. Various vaccination strategies have also been explored, including killed lymphoma cell extracts, DNA vaccines targeting telomerase reverse transcriptase, which has shown increased survival in dogs with B-cell lymphoma when combined with chemotherapy, and autologous heat shock protein vaccines. Adoptive immunotherapy using nonspecific autologous T cells has also shown potential in increasing remission duration and overall survival in dogs. Miscellaneous therapies include retinoids, which have shown some remission in cutaneous lymphoma. Targeted therapy is an exciting frontier, with potential targets including anaplastic lymphoma kinase and NF-κB pathways. NF-κB inhibitors like bortezomib have been shown to reduce NF-κB expression and inhibit cell proliferation in canine lymphoid cell lines. The tyrosine kinase inhibitor mazitinib is being explored as an alternative for canine epitheliotropic cutaneous T-cell lymphoma. Even viral lympholytic therapy using canine distemper virus is being investigated for its ability to infect lymphoid cells and induce apoptosis. Finally, let's talk about prognosis. This is complex and depends on many factors, often evaluated using an approach similar to the International Prognostic Index used in human non-Hodgkin lymphoma. Clinical data often provide important clues. Female, small breed dogs in earlier stages, 1 to 4, without systemic signs generally have a more favorable prognosis than male, large breed dogs with stage V disease or systemic signs. Extranodal lymphomas, such as gastrointestinal, hepatic, mediastinal, cutaneous, and renal forms, generally carry a poorer prognosis than the multicentric form. Pretreatment with glucocorticoids negatively affects the response rate to chemotherapy. Pretreatment clinical pathology results also factor in. While absolute lymphocyte count and neutrophil lymphocyte ratio haven't been consistently predictive for progression-free survival in dogs, increased neutrophil and monocyte counts have correlated with a shorter disease-free interval. Hypercalcemia is a clear poor prognostic indicator, often associated with T-cell lymphoma, though its presence in T-cell lymphoma may not further worsen the outcome beyond the T-cell type itself. Histology, immunophenotype, grade, and proliferation indices are paramount. In general, T-cell lymphomas have shorter remission and survival times than B-cell lymphomas. Most T-cell lymphomas are high-grade and aggressive, with a median survival of around 159 days. However, a specific type called T-zone lymphoma, often diagnosed in older golden retrievers with lymphadenopathy and peripheral lymphocytosis, is a low-grade lymphoma with a good prognosis, with median survival times over 2 years. Proliferation markers like Ki67 and aggrerophilic nuclear organizer regions, which reflect cell division, correlate with tumor grade and have prognostic value, unlike mitotic index and pCNA expression. Molecular biology and other prognosticators are providing increasingly detailed insights. Gene expression profiling can subdivide lymphomas into molecular subtypes that correlate with survival, similar to human diffuse large B-cell lymphoma. Specific genetic findings like trisomy of dog chromosome 13, high-class II major histocompatibility complex expression, the absence of minimal residual disease in the blood, and certain immunoglobulin heavy-chain variable region gene expressions have been associated with better prognosis. Conversely, expression of p53 and p16 messenger RNA and increased survivin expression have correlated with shorter survival or disease-free periods. Regarding biomarkers, as mentioned earlier, serum thymidine kinase 1 levels have shown prognostic value. Looking ahead, the journey to conquer canine lymphoma is far from over. Despite significant advancements in our understanding of its genetics, molecular biology, and diagnosis, this has only marginally improved prognosis. Chemotherapy, though a mainstay, seems to have reached a plateau in what it can offer, with more intense protocols often increasing toxicity without improving outcomes. A major leap forward would involve finding ways to prevent, delay, or circumvent drug resistance. As local therapies like surgery and radiotherapy have limited roles, the focus is increasingly shifting toward other systemic treatment modalities like immunotherapy and targeted therapy. A detailed understanding of the molecular pathways involved in lymphomagenesis is absolutely essential for these targeted approaches to truly succeed. The ongoing research into canine lymphoma is not just for our pets. It also holds immense potential to inform and accelerate discoveries in human cancer medicine, truly making our dogs our best friends and a valuable model for comparative oncology. Thank you for listening. The titles for the referenced papers are in the video description. From Vet Med Digest, where we keep minds inspired, hearts light, and tails wagging.